Imagine if a routine maxillofacial scan, maybe one you'd get for dental work, could also give you an early warning about a systemic bone condition. Well, that's exactly what we're looking at today, a fascinating pilot study exploring how a 3D analysis of the facial skeleton could potentially flag osteoporosis, long before a fracture ever happens.
You see, the real challenge with osteoporosis is that it's often a silent disease. The first indication is usually a fracture, but by that point, a lot of bone deterioration has already taken place. This research tries to change that by asking a critical question. Can we find hidden, quantitative signals of bone fragility in scans that are already being taken for other reasons?
Okay, here's how we're gonna break it all down. First, we'll dig into why we need a new way to screen for this in the first place. Then, we'll introduce this novel method called 3D radiomics and look at how the study was designed. After that, we'll get into the actual data and finally talk about what this could all mean for the future of assessing bone health.
So, to really appreciate what this study is trying to do, we first need to understand the current situation, the tools we have now, and where their limitations are.
The condition we're focusing on is, of course, osteoporosis. And it's important to know it's not just about losing bone mass. What's really critical is the degradation of the bone's internal structure, its microarchitecture. That structural breakdown is what truly drives the increased fragility and risk of fracture.
So how is bone health typically measured? Well, the standard metric is something called a T-score, which comes from a DXA scan. You can think of it as a standardized score for your bone density. Anything at or above -1.0 is considered normal. If you fall between -1.0 and -2.5, that's a warning stage known as osteopenia. And a score at or below -2.5 is the official threshold for an osteoporosis diagnosis. And right here is where we see the potential for a major shift. The current standard, DXA, is great, but it usually happens in a specialized clinic, often after a problem is already suspected. The method this study proposes, using cone beam CT scans, completely flips that around. These are routine scans for all sorts of maxillofacial procedures. This means we could potentially screen people for bone health issues opportunistically, without them needing an extra appointment or any additional radiation exposure.
So let's talk about the technology that makes this all possible. We're moving into the world of 3D radiomics, which is really the engine driving this entire study.
So what exactly is radiomics? Well, imagine a computer algorithm that can look at a medical scan and see subtle textures and patterns completely invisible to the human eye. Radiomics is the process of extracting those patterns and turning them into objective, hard numbers. It allows for a much deeper, data-driven analysis of what's going on inside the tissue. The core idea here is actually quite elegant. So many patients are already getting these CBCT scans for maxillofacial work. That means these images represent a massive, completely untapped source of data. This study is proposing we use that existing data for an extra layer of screening, a way to opportunistically look for the earliest signs of systemic bone loss.
Okay, so let's get into the nuts and bolts of how the researchers actually designed this investigation. It's a really interesting mix of analyzing patient data and using some clever digital models to validate their work.
The whole workflow was very systematic. The researchers started with 68 existing CBCT scans from patients. Then, within those scans, they carefully outlined 309 specific 3D regions in the maxilla and the mandible. From each of those little regions, they used computers to extract a whole host of radiomic texture features. And then came the most important step. They checked to see if those features correlated with the patient's actual T-scores from their official DEXA scans.
Now, this next part is absolutely critical to making sure the science is solid. How do you know the features you're finding are because of real changes in bone structure and not just, noise or quirks in the imaging? Well, you use a validation tool. In this case, they used synthetic 3D digital models, or phantoms, where they could control the exact structural properties to mimic different stages of bone health.
And here you can see what those digital phantoms looked like. The models on the left simulate a very controlled, gradual decrease in bone density. The series on the right models the whole progression of the microarchitecture from healthy bone all the way to the very sparse structure you see in advanced osteoporosis. By running their algorithms on these known models, they could confirm that yes, the radiomic features were changing in a predictable way that matched the structural breakdown.
All right, this brings us to the results. What did all of this analysis actually turn up? Let's look at the quantitative findings that came from comparing those radiomic features to the patient T-scores.
The analysis found a really clear signal in the noise. Out of 399 texture features they looked at, a solid 36 of them showed a statistically significant correlation with the T-score. This immediately gave the researchers a much smaller, more focused group of promising markers to investigate further.
Here's a perfect example. This chart shows a strong negative correlation for a feature called difference variance. Basically, as the value of this texture feature goes up along the bottom axis, the patient's T-score, our measure of bone health, tends to go down. This is a pretty good sign that this particular feature might be a valuable indicator of bone deterioration.
And then you have the opposite. This feature, called sum variance, shows a positive correlation. Here, you can see the data trends upwards. That means higher values of this texture feature are linked to higher and therefore healthier T-scores. It's a great illustration of how different computational features can capture distinct aspects of the bone's microarchitecture.
This table gives us a snapshot of some of the best performing features. You can see that one from an autoregression model, which looks for repeating patterns, had the strongest negative link. And on the positive side, features from things like Gabor transforms, which analyze texture at different scales, also performed really well. The big takeaway here is that several different analytical methods all point into the same conclusion.
Now, this is a crucial point. It's one thing to find a correlation, but it's another to ask how much predictive power it has. An R-squared value tells us how much of the variation in the T-score can be explained by a single texture feature. And here, the strongest single feature could account for almost 17% of that variability. For a pilot study using one marker, that's a pretty significant finding. So given these promising early results, let's zoom out and consider the bigger picture. What are the broader implications of this research, and what are the next steps to move these findings closer to actual clinical use?
Of course, it is absolutely essential to be clear about the study's limitations. This was a pilot study, so the number of patients was small. These findings are preliminary, and they absolutely need to be validated in much larger, independent groups of patients. And because this was more of an exploratory analysis, more work needs to be done to combine the best features into a single, robust predictive tool. In the end, the study's own conclusion really says it best. The authors state that this method may provide a non-invasive, supplementary tool. And that word, supplementary, is key. The goal here isn't to replace the current standard of care, but to add to it, to provide a new way to catch early changes in bone quality using data we already have.
So what's the ultimate takeaway? This research points toward a future of more connected healthcare, where data from a routine scan in one medical specialty could provide crucial, early warning signs for another. It suggests that your next maxillofacial scan might hold more than just a picture. It could hold a key to understanding your broader systemic health.
Welcome to the debate. Millions of patients undergo routine cone beam computed tomography, or CBCT, of the maxilla and mandible every year.
Right.
What if these standard scans contain the earliest diagnostic indicators of a structurally compromised skeleton? Today we evaluate a 2026 pilot study examining whether extracting three-dimensional radiometric texture features from these scans can serve as a reliable, opportunistic screening mechanism for osteoporosis. I argue that evaluating this texture in 3D space provides actionable, early diagnostic data.
And, well, I contend that while the theory is sound, acquisition variables and structural nonlinearities currently compromise the clinical validity of these radiometric markers. The diagnostic output is simply not yet sufficiently reproducible.
Consider the established diagnostic paradigm. A standard dual-energy X-ray absorptometry, or DXA scan, evaluates bone mineral density as a measure of finite mass.
Correct.
It is effectively like weighing a sealed box to determine its overall integrity. By transitioning to 3D spatial analysis of the trabecular microarchitecture in the maxilla and mandible, we are essentially looking inside that box to inspect the support beams.
A compelling analogy, but
If I may. The study demonstrates that gray-level co-occurrence matrix parameters exhibit monotonic increases that correlate directly with standard DXA T-scores. These parameters map exactly how gray pixels relate to each other to define physical structure.
I look at this mechanism with a measure of caution, though. The quantitative extraction of these 3D radiomic features remains methodologically unstable.
Unstable in what specific regard?
Well, while the algorithms map pixel relationships, those pixels are highly sensitive to CBCT acquisition settings. Specifically, variations in the anode current explained nearly 30% of the variance in texture features like some variants.
I see.
To use a structural comparison, attempting to measure the fine texture of a carpet is impossible if the light bulb in the room keeps flickering between dim and bright. The variation in the X-ray tube current alters the texture reading entirely independently of the patient's actual bone mineral density.
That is a fair comparison, though I would interpret the study's control measures differently. The researchers isolated the intrinsic 3D spatial properties from that imaging variability by utilizing synthetic 3D reference phantoms.
Right, the simulated spheres and ellipsoids.
Precisely. By computationally simulating those and the trabecular networks, they demonstrated that the algorithms accurately reflect physical microarchitecture when variables are controlled.
When controlled, yes.
So, if we were to mandate a standardized anode current across daily diagnostic imaging, would that not mitigate the acquisition confounder?
That might resolve the illumination issue, but it does not resolve the algorithmic interpretation of the structure itself. The phantom data demonstrates significant inconsistencies when mapping simulated trabecular models.
You are referring to models D1 through D4.
I am. The radiological texture values exhibited non-monotonic trajectories, meaning they did not follow a predictable linear progression. Instead, the measured values initially decreased from D1 to D2 before increasing toward D4.
Right, but that is because as the bone begins to degrade, the physical spaces between the trabecular networks enlarge.
Exactly. And in those early stages of degradation, the algorithm occasionally interprets those enlarging empty spaces as a smoother texture.
Ah, I understand.
Yes, it reads as smoother before the structure becomes definitively rough and degraded. These structural nonlinearities make establishing a definitive baseline diagnostic threshold highly complex.
I acknowledge the mechanical difficulty there, but let us evaluate the clinical significance for daily diagnostic imaging. Leveraging pre-existing Maxwell facial scans provides critical lead time for intervention.
It would be highly efficient, certainly.
It is particularly vital for mitigating medication-related osteonecrosis of the maxilla and mandible. That is a severe complication associated with bisphosphonate therapies.
Indeed.
Opportunistic extraction of these 3D spatial descriptors allows practitioners to detect microarchitectural deterioration long before an incidental fracture occurs, and it utilizes scans that are already captured for routine dental practice.
The theoretical efficiency of opportunistic screening in dental practice is recognized. However, daily diagnostic imaging relies on highly heterogeneous equipment.
You mean the variation across different CBCT devices?
Correct. Without rigorous hardware harmonization across different devices, the baseline measurements fluctuate too significantly.
I see your point.
Until scanner output is standardized, these 3D spatial measurements cannot operate as reliable diagnostic tools over standard DXA protocols. The variance introduced by the hardware currently precludes definitive clinical decision-making.
To summarize my position, 3D spatial texture analysis of the maxilla and mandible provides a non-invasive supplementary pathway for opportunistic skeletal assessment.
Yes, we agree on the potential efficiency.
And emphasizing the evaluation of texture in three-dimensional space yields critical diagnostic lead time for structural deterioration.
And my conclusion remains that methodological standardization and hardware heterogeneity must be resolved before clinical integration is feasible. Spatial radiomics requires rigorous empirical validation before it can dictate patient management.
The analysis of spatial radiomics remains an evolving domain within diagnostic imaging.
It certainly does.
We are left to consider whether the future of skeletal assessment will rely solely on standard measurements of finite mass, or if clinical practice will adapt to reliably navigate the intricate spatial complexity of the microarchitecture itself.